This episode of NeuroNights comes to you with support from the Ohio State University Wexner Medical Center, which has dedicated brain injury specialists at each level of care. Our inpatient and outpatient services are CARF accredited and a part of the brain injury model systems. For more information on our brain injury program, please scan the QR code or go to go.osu.edu/brain injury.
Some of you guys were on last week when we talked about research in TBI. Today, we're going to talk about some TBI recovery, some prognosis, imaging, and some new frontiers that are out there that are still under research, but things that you might be hearing about on the news or other things going on. So, and like I said, Alicia is going to be working with me today on this presentation, so you don't have to hear me talk for an entire hour. So anyway, recovery in TBI. So a lot of people will always ask me, like, how am I going to get better? What's going to happen? What's my trajectory of recovery? So we're really talking about traumatic brain injury at this point. And so there's a lot of things that can predict how people's outcome. So some of the main things that we talk about for predictors of outcome are going to be age. So, you know, younger individuals are going to get better faster and usually have a faster trajectory of recovery or a better chance of full recovery. And then if there's any history of previous TBI. So, you know, we hear about our multiple concussions patients, and we hear about chronic traumatic encephalopathy. So really, if there is a history of previous brain injuries, whether it's concussions or severe brain injuries, that is taken into account. And then we talk about loss of consciousness. So how long is the loss of consciousness, or how long are they in a coma? So loss of consciousness is, you know, the time that you get the injury and until you come to, but you're not necessarily making memories at that point. It's when people say, well, I was talking to you, don't you remember? And then it's from the time that you lose consciousness to the time that people are saying that you're awake. You may not remember being awake, but people will say that you're awake. So, you know, when we talk about mild brain injuries, we're talking about people that have loss of consciousness less than 30 minutes. You know, moderates are 30 minutes or an hour to up to 24 hours. And then severe is if you have a loss of consciousness for longer than 24 hours. So with that comes coma. So, you know, people are always asking, well, you know, I was in a coma for 3 weeks, 6 weeks, but coma really means the time that you started opening your eyes. So you may not be fully conscious or awake, but you might have eye opening spontaneously. And that's when you come out of a coma. So the time that we determine when people are out of a coma is when your eyes first open, even if you don't have recollection or you're not communicating or following commands, because then there's other states of disorders of consciousness, which is minimally conscious state, and then the unresponsive wakefulness state. I'm not going to go into those since those we don't really talk about recovery when we're talking about the different states, but when we're talking about predictors, those are the things to think about. And then we look at imaging findings. So, you know, the amount of hemorrhage that people have, the amount of contusions, whether people have something called diffuse axonal injury, where those are small little hemorrhages that can be throughout the brain because of shearing injuries, or you might hear I had a shearing injury, and that means that I had diffuse axonal injury. And so we look at that to see how severe someone's injury is, and you know, how much damage or how much blood or bleeding or contusions they had. And then we look at the length of post-traumatic amnesia. So some of you who had more severe of a brain injury will have potentially heard that term, post-traumatic amnesia. And what that means is the length of time that it takes for you to start laying down new memories. So you could be awake, you could be talking, you could be walking, but you may not be laying down new day-to-day memories. So when you start being able to lay down new day-to-day memories, so I usually will ask people, you know, what's the first thing you remember when you woke up? And some people will say, I remember waking up in the emergency room, or I remember waking up in the hospital 3 or 4 days later. And then I'll ask them, well, do you remember everything that happened after that? And sometimes people will say, well, I remember waking up, but I don't have full memories. I have little bits and pieces. So they still have some post-traumatic amnesia. It's really when they are consistently able to put down those memories day to day. So those are some of the main things that I look at for predictors for outcomes. So, people that have a longer coma duration, longer loss of consciousness, much more severe imaging findings, a longer length of post-traumatic amnesia, they're on the kind of slower end or the poorer prognosis for full recovery. So like I said, at the bottom, I'm right, depending on the severity of injury. So I will tell people you had a mild, moderate, or severe injury. And that I determine based on your loss of consciousness, length of post-traumatic amnesia. And then if you guys have heard of something called a Glasgow Coma Scale. So when people come into the emergency room, they're given a Glasgow Coma Scale, and that is a scale that looks at eye opening, motor, like how much you're moving, are you responding verbally, and then they'll give people a score from that. So that tells me the severity of their injury. Then we talk about complications. So what kind of complications did people have with the injury? Did they have other things happen? Not only was the head hurt, but did they have a broken bone, or did they have a bleed somewhere? Did they have something else that requires surgery or medical intervention? Because every complication is also putting a stressor on the body. So your brain is already stressed from the injury, and then you have other complications that are stressing your body as well. And then pre-existing health. Does the individual have previous history, like I talked about brain injury, but other things like a stroke or, other medical conditions that are already making them a little bit more debilitated or having a little bit of a consequence. So, those are the things that I look at when I'm talking about recovery from TBI and when I'm talking to people about predicting of outcome or predicting how they're going to progress. So, this is a little blurry. I'm terribly sorry. But anyway, you guys can see here. So this is kind of a scale that I use, and this is all, again, traumatic brain injury. If we're looking at other types of brain injury, like, anoxic brain injury or acquired brain injuries, it's a different scale. But what this is it talks about kind of when people had their injury, which is right here, if you can see my mouse, and then their pre-existing function. So when they have pre-injury function, and then they have their injury, and then they kind of come down to the level of loss of consciousness coma, their post-traumatic amnesia time frame, and then if they're having memory problems. So when you have someone with a mild TBI, that's this top one, they're really not going to have this coma state. They might have a very brief post-traumatic amnesia state. And their pre-morbid level of functioning might be right here, kind of, let's call that 100%, that you might get up to like 95 to almost 100%. It looks like it gets almost close to where they were before. So people with milder head injuries, like concussions, will get better much faster and will get closer to their baseline. And this is what we talk about down here, is talking about time. So we have 3 months, 6 months, 9 months, and 12 months. Now this is only up to 12 months. Now there are a lot of studies out there that say people continue to recover even up to 5 years after their injury. We've gained a lot of that data from the military population that's come back from OEF and OIF, and really being able to follow them along in their progress. And we've been able to see that previously we used to tell people, what you have in a year is what you'll get. And then we'll, if you get anything beyond that, it's a good thing. But we've actually, and that was old data, that's from 20 years ago. As we start getting more and more new data, we then expanded that to 2 years. And we were saying, okay, you'll make recovery up to 2 years out. And then what you have at 2 years is what you have. And then anything beyond that is just icing on the cake. But exactly, Michelle's putting up there. But now we have data that people can get up to 5 years out. We're still seeing people progressing really well and continuing on that recovery trajectory. So as we get more data, as we get more interventions for people, as we learn a lot more about brain injury, we're learning that there is a lot more time that people can have to continue to recover, as long as we keep people healthy and as long as we keep them kind of going on this trajectory of recovery. So then we look at moderate brain injuries. So when they will have they'll have a coma state or a small, it could be brief, and then they'll start waking up, and then there'll be this PTA's post-traumatic amnesia again. And their post-traumatic amnesia, notice it's brief up here, it's a little bit longer in moderate brain injuries, and they will get better, and their slope will continue, and they'll get closer and closer to their pre-existing or pre-injury level of functioning, which is great. But they still may not be 100%. They might be just below that. And then when we talk about our severe brain injuries, so they have a much longer post-traumatic amnesia. It could be beyond even 3 months. It could be anywhere from 1 week to 3 to 4 months. And then they will start getting better, but they're going to be a lot slower, shallower of a slope. And then you'll notice that this slope will just slowly rise, but it won't be as fast of a recovery as we see in mild brain injury. So like I said, the severity of injury matters, what kinds of things are going on with them, how long their post-traumatic amnesia is. So this kind of graph gives you a really nice depiction of those predictors that I was talking about. So when we talk about imaging, I always get the question, when are you going to do another CAT scan? When are you going to do another MRI? How often do I need to have this imaging done? So usually the CAT scans, they're definitely done in the emergency room. They're quick, they're fast. We can determine looking at bleeds and fractures and everything like that on a CAT scan. They're really quick to do. But if someone comes in with a milder injury, we may not necessarily do a CAT scan right away if they have a concussion. And to look at that, we look at how old are they? Are they having any neurological symptoms? Were they using any blood thinners? What was their mechanism of injury? Was it like a high-speed trauma? And what was their level of consciousness? Are they awake? Are they not awake? What is going on? So we use the CAT scans usually initially. And then if we're noticing a bleed or anything like that, then usually what we'll do is we'll watch those. The neurosurgeons and the critical care teams will say, okay, let's repeat a CAT scan in 6 hours or 8 hours, see if anything's getting worse. If it's worsening, then they'll determine the next treatment. If it's not worsening, then we'll get one potentially 24 hours later. And if that one still looks stable, they'll kind of let things continue to progress and maybe get a CAT scan 2 to 4 weeks down the road. Now, MRIs are a different story. So if we have someone that we initially have a CAT scan on, and they're just not getting better, and we're noticing in the hospital that things aren't improving, the CAT scan didn't look so terrible, what are we looking for? So that's when we look at an MRI. And we look at an MRI depending on what we're looking for. So if we're looking for someone to find out, did they have diffuse axonal injury? So if we said someone with a high-speed motor vehicle accident, and they had a lot of shearing injury on their CAT scan, then we would get an MRI. The MRI will tell us how much of that shearing injury it is, what part of the brain it hurt. Did it hurt some of the outside of the brain, inside of the brain, the brain stem? So we look at that when we're thinking about the recovery not being as expected. There's ongoing neurological deficits that we can't figure out why it would be when the CAT scan looked one way. So it may or may not be completed in the hospital. It definitely is not completed in the emergency room, but it could be completed down the road. But we may not complete it for all patients with a concussion initially, just because concussions, we may not be able to see anything. And so it may not even change anything for us. So just depends on kind of how we're looking at a patient, what's going on. So again, how often is imaging done? That's the question I get the most. In the acute phase, it depends on the injury. Like I said, if someone has a bad bleed, they might get a CAT scan every 6 to 8 hours. They may get one at 24 hours. They may get one daily. It just depends on what's going on with their injury. But in the chronic phase, usually when people get to my clinic, my outpatient clinics, or even to my inpatient rehab, they're pretty stable. They have to be by the time they come to me. So we won't usually get a CAT scan or an MRI in the inpatient rehab unit or even as an outpatient unless they need it for follow-up after surgical interventions, or if there's any change or worsening in symptoms, then we'll get a CAT scan or an MRI depending on what we need to do. Usually an MRI I get as an outpatient if there is worsening of symptoms, but CAT scans are quick and easy for me to get on the inpatient rehab unit. So when we talk about the CAT scans, like I said, they're pretty quick. You can get them in less than 15 minutes. It really helps with looking at blood and fractures, skull fractures, and there's really no contraindication to them. And it's very easy to access. Every hospital has it, even the smaller hospitals have it. When I first started in medicine in the late 90s, I'm dating myself, but early 2000s, late 90s, not every hospital had a CAT scanner. But it just became what we had. And now everywhere has a CAT scan. It's really easy to get. Some people have multiple CAT scans in their hospitals, depending on the size of the hospital. But MRI, so MRI is tough. There's so many different MRIs out there. You'll probably, do a Google search or, and talk about MRI, and they'll give you a list of all these different kind of MRIs. There's different types of MRIs in the fact of what we call Teslas, how powerful the MRIs are. And so really, when we're looking at MRIs, we use them for looking at higher level things. So it does take longer. It takes, depending on how many body parts you're imaging, a brain could take up to 30 to 45 minutes to image, depending on what kind of images you're asking to get. But it's much better at evaluating those tiny little microhemorrhages, or what we call diffuse axonal injury. It's not always easy to access. Not every hospital has, a 6 Tesla MRI. They might have a 2 Tesla or 3 Tesla, or they may not have one at all, depending on how small rural hospital you're at. But some contraindications, if you have any metal implanted into your body that's not MRI compatible. So they'll ask you about tattoos. Of course, they'll ask you about piercings and all of that stuff too. But there will be a lot of questions with MRIs, whether you can have an MRI or not. The other thing that I get a lot of is people can get claustrophobia in an MRI. It is a really long tube. People have to be put into it head first. So, sometimes people need medications or something to help them, with their claustrophobia or their nervousness during an MRI. So there's different images within the MRI. So you'll hear, or when you see your reports, you'll hear flare intensity or T2 flare or T1 flare. Those are just some of the different ways that we can look at the MRI, and they're different types of signaling that we can see in the MRI. Those are typical. All MRIs will talk about T1, T2, but not all MRIs will talk about gradient echo. So gradient echo is another type or another part of the image of an MRI that we can look at what we call punctate microhemorrhages. Diffusion tensor imaging is where we can actually see the axons and see if there's small little tears or areas of disruption in the axons. And then there's MR spectroscopy, which actually looks at the different levels of different chemicals in the brain. So there's things like NAA and choline, and we look at how their ratios are to see about prognostication for recovery. That being said, gradient echo is easy to get at majority of hospitals. It's already into the MRI package or how they have for their different imaging modalities. But diffusion tensor imaging is not available everywhere. It's available, the VAs, a lot of the VAs will have it, like the polytrauma centers, but it's not readily available at every academic or medical center. The reason why is it's still considered experimental. It's still considered to be in a study phase. And the other thing is that you need to have very trained neuroradiologists to read the diffusion tensor imaging. So it's not readily available yet, but we're hoping with all of the data that we're getting out there that we will be able to start using it more readily to help with kind of looking at patients with brain injuries. So I'm hoping that we'll be getting it here to use clinically soon. We do have DTI at Ohio State, but it is still only in research use thus far. And then MR spectroscopy is one that is also available at some, not every location, but it can be available at some. And that's looking at the different ratios of the chemicals. So we do have that here at Ohio State, but we don't have it, again, readily to use. It's still in the clinical research realm. But these are new imaging techniques that are coming out. They've been coming out for several years. It's just getting enough data so that we can show that it should be a routine thing to do with MRI. And also getting radiologists that can read them. So what can we do to promote recovery? So, we looked at imaging, we talked about, these predictors of recovery, but what can we do to promote it? So what I talked about is we definitely want to manage comorbid or medical conditions. You want to abstain from any substances, nicotine, alcohol, illicit substances. And I usually will say, at least from the alcohol standpoint, at least a year to abstain from it, just because what I tell people is that you have brain cells that are trying to heal and you have damaged brain cells. You want all of your good brain cells to work as hard as possible to help you get better. And if you use alcohol, it's going to damage those good brain cells. And you don't want that because you already have damaged cells that are trying to get better. So if you can abstain from alcohol for a year, great. That is going to help you in the long run. And then we talk about managing sleep. We talk about maintaining physical activity, participating in rehab, and then preventing another injury. So, I tell people, especially in the first year after their injury, if you need a helmet for the activity, it's something you should stay away from for that first year. Just because it is, you can get really a more severe injury if you're still recovering from your previous injury in the first 12 months. So even if you had a moderate brain injury, but then you get a mild concussion, that mild concussion could seem like a moderate brain injury because you are already trying to heal from a moderate brain injury, if that makes sense. So like we talked about before, we were promoting recovery. One of the big things that I talked about was managing sleep. So in sleep disturbances, quite a high number of our population can have sleep disturbances, up to 70%. And so those sleep disturbances can be insomnia, hypersomnia. People will talk about they just want to sleep all the time. Sleep-wake cycle disturbances where they're up at night but sleeping during the day, or have kind of erratic sleep where they're sleeping for an hour, waking up and sleeping, or they could develop sleep apnea. So one of the studies we did here through the model systems, and it was a multi-center study, was looking at sleep apnea and the prevalence of it after someone's had a moderate to severe brain injury. So we did find that there is a correlation to people developing sleep apnea, whether it's a central sleep hypopnea or an obstructive sleep apnea after they've had a brain injury. So how does poor sleep affect daily functioning? We talk about this a lot: cognitive slowing, mood changes, or mood swings, decrease in physical endurance. Overall, I know when I don't sleep well the night before, my next day is very difficult to manage. And I haven't had an injury to my brain. And so when we talk about people that have had brain injuries, we really want you to get good sleep. Sleep, I cannot emphasize enough how important good sleep is and keeping yourself on a schedule. So how do we manage sleep? There's so many things we can do. People will talk about sleep hygiene. So these are some of the Sleep Foundation has this handout for patients, and our TBI Model Systems Knowledge Translation Center, I'll put another pitch in for that, and Alicia can put it on the chat box, but that has a lot of handouts for sleep, managing sleep, these type of sleep hygiene checklists, things that you can do to manage sleep. So, some of the big things that we want to do from just the hygiene standpoint is You can take naps, but don't take naps that are 3 or 4 or 5 hours long, because then you're not going to be able to sleep at nighttime. But you can take a nap but set an alarm for a half an hour, 30 to an hour. But taking those longer naps are not ideal. Avoiding stimulants like caffeine before sleep, that's also not great, because as we know, we use caffeine to help keep ourselves awake. Exercise is good, but not doing heavy strenuous exercise right before sleep. And then soaking up some natural light. So, getting outside during the day. Light exposure really helps. And then, turning everything off at night. Get a bedtime routine going, whether it's changing your clothes, brushing your teeth, kind of winding down for the evening. Don't have screens on right before bedtime. So, turning off TVs, phones, computers, all of that stuff, at least a half an hour before you want to go to sleep. And then your bed should really only be for sleep. Don't keep the TV on, or, use your phone or listen to the radio or read while in bed. Like, the bed should be a place where your body just recognizes it for sleep. If you go to sleep and you can't fall asleep, get up, go sit on the couch, go sit in a recliner, and then try to do something at that point to try to keep, kind of calm your mind down, listening to music or, quiet music or noise machines or anything. And when you start feeling sleepy, get back to bed and try to go to sleep. But the toughest part is that when you're so tired, but you can't fall asleep, you just want to lay in bed and hope that you're going to fall asleep. But then your body gets used to that and then creates that as a routine instead of saying, oh, there's the bed, and falls asleep. So there's medications that can be used. The most common things that we use are melatonin, and we know melatonin is a natural hormone we all have that increases in our body, in our brains when we go to sleep. After a brain injury, it could be disrupted. A lot of the over-the-counter sleep aids have diphenhydramine, or better known as Benadryl, in them for the over-the-counter ones. So, and those are okay to use, but they aren't ideal for long-term use. They're okay for as needed. And then there's prescription medications. So I definitely discuss the optimal medication with your physician. Many have side effects. Many have interactions with other medications. So we definitely want to make sure that whatever medication, if you're going to use for sleep, you are discussing with your doctor and reviewing your full med list with them as well. And then there's sleep testing. So what do we do to look for different kinds of sleep disorders? Like I talked about with hypersomnia, or there could be narcolepsy or sleep apnea. We want to do a sleep study. Usually that's overnight, or sometimes they'll do it during the day if someone's have excessive daytime sleepiness. And that's usually done through our sleep medicine clinic here at OSU. And there are sleep medicine clinics at quite a few of the hospitals around the state. So they're usually done through a sleep medicine clinic. And that can talk about all different reasons why you're having trouble with sleep. If the hygiene's not working, if some of the medications aren't working, then we kind of go into the higher level. Let's talk to a sleep medicine physician about testing for reasons why I might not be sleeping. Well, we will move on. I'll let Alicia take the reins now.
Perfect. So a couple other things that we can do just to help promote recovery in general is just staying physically active. And this is kind of my area of specialty with myself and my team. As I was introduced earlier, I am a physical therapist at Ohio State. And I know many of you have come through our clinic and worked with the clinicians on my team. So one of the big initiatives that we have within our profession right now, especially for neurologic conditions, which brain injury falls under, is the idea that intensity matters. So in general, just being active is good for you, but there is some research to support that it should be at a certain threshold to really try to thrive and have the body start to facilitate recovery. So recommendations right now are to exercise at 60 to 80% of your heart rate max. Heart rate max is often calculated by taking 220 and subtracting your age. So it's going to be individualized depending on how old you are. And then another easy way is that you should be exercising at a rate of perceived exertion of 12 to 16, which means that something should be moderate to hard. It's the scale that rates it all the way from 6 to 20, but relatively easy. You can search that and find that really easily. And they're recommending about 20 to 30 minutes and usually about 3 to 5 days a week. So you can get out, be active, and that's going to help you stay healthy, promote recovery, and just overall general health and wellness. And the mode and type is going to definitely be based on your type of physical abilities. Like Dr. Bavishi said, individuals that are living with brain injury and surviving with brain injury can be walking around. They can have assistive devices. They can be in wheelchairs. Some people need people to help them. So we can find ways for you to be physically active. And if you're not sure where to start, you can consult your doctor or your rehab team. I'm always an advocate for community integration into the gym. But at times, sometimes you just need a little tune-up, even when you're surviving with your brain injury. And that's where your rehab team comes into play. We are movement specialists and can definitely help you on your health fitness journey and let you know of resources that can help meet your needs and interests. So you could go to the next slide. And some of the benefits that you can get from physical activity in general, like I said, is your physical health and function. So helping you to prevent comorbidities like blood pressure issues, weight issues, and just prevention and management of disease. The less that you have going on, the better off that you'll be in a simple state. It can be good for your mental health in terms of stress management. It can also promote improved sleep, like Dr. Bavishi was talking about earlier, and help your emotion regulation and mood. You have some neurotransmitters and hormones that are released with exercise, and it's a great way just to stay active. And then cognitive function, even, it can help with improved learning, memory, and intention, social engagement. So you can get peer interaction by doing it in a group setting or in a group activity through like adapted sports or fitness, and then increased productivity. I know I feel better when I get up and I work out in the morning, even on days that I don't sleep well. So it definitely helps to balance it out. I did see a couple questions.
Yes. So yeah. Grace asked, what are good ways to exercise in the winter months, especially with COVID?
That's fantastic. And actually, we did a presentation on this, and I think just the slides, I don't think there's a formal recording, but the slides from my presentation are up on the NeuroNights as well. But a couple things that you can do are, if your comfort level is there, gyms are reopening, that you can go to a gym and exercise there. If you're uncomfortable going to a gym, I can do a couple plugs, which is Franklin Park has an adapted gym, and they have people that they're able to do one-on-one training. It's free, so you don't have to pay for gym membership, but you do need a referral. So typically, like our physical therapy team, we can write you a referral for that. Ohio State, we also started this program called NeuroWell. It is fee for service, but we have a lot of clients that, you know, just are not fully comfortable going to their local YMCA or Planet Fitness or whatever type of gym that you're going to. So you can do group exercise sessions with our exercise physiology techs. It's twice a week and then $50 a month. So you're paying about $50 a month for small group and or one-on-one training within our clinic at Martha Morehouse. So if you're interested in that, I can give some information to Kadar and Julie and make sure that's sent out to all you guys. But then even just simple things, there's a lot of online videos for health and wellness within your physical abilities. There's adapted yoga that you can do. And even if there's nothing else, we were talking about just going up and down your stairs. If you can walk up and down your stairs a few times, getting up, walking around your house, simple things like that. When the weather is a little bit nicer, get outside, do gardening, anything that just gets you moving and off the couch or outside, going for a stroll that's distancing yourself. Those are all fantastic ways that you can stay active. And then to answer Perry's question, yes, it was 60 to 80% of your max heart rate was what they were recommending. So we get this question a lot just in general, and this can be a quick overview, but so what can physical therapy do? And then there's a slide on occupational therapy and speech therapy. So like I said, we're considered movement specialists. So anything functional mobility related. So Hemiplegia, meaning half of your body, that's pretty common, like the right or left side is impaired after brain injury. Tetraplegia means that all 4 limbs are impaired. Physical therapists, we tend to work on gait is walking and balance, posture, range of motion. So like stretching, you might have contractures related to your spasticity or just not moving in general because of lack of function. Coordination, activity intolerance, and that spans all the way from concussion up to severe brain injury. Pain, sensory integration is a lot of like vestibular balance type of stuff. And then just making sure that you're safe cognitively with your surroundings to move around the community. Occupational therapy, which is on the next slide, very similar in terms of range of motion, spasticity, coordination, but some other things that you might not be aware of is that occupational therapy can also help with vision, functional problem solving, return to driving, and pretty much anything that's related to what we call self-care, ADLs, which is activities of daily living, which is like bathing yourself, dressing yourself, grooming, doing cooking, planning to go to the grocery store, things like that. Occupational therapy can help you optimize or improve. And then speech therapy is considered a therapy for functional cognitive and speech impairments. So they can help with communication, memory strategies, attention, organization, completion of your daily routine, and then how to organize, manage appointments. They're by no means accountants, but they can help you come up with strategies for helping to manage your money by yourself, medications, so you can be independent and sorting and making sure that you're doing that appropriately with timers and different things like that. So, like Dr. Bavishi said, 2 different MRIs can play. So we can have, or the same MRI can have different presentations in real life. And that's kind of where we come into play in terms of really highlighting improvements in function over time.
I know we're running short on time, so I'm going to move forward to the next part of this because I wanted to talk about, traditionally how there's medications we traditionally use to assist in recovery. And some of you may have heard of some of these medications, amantadine, methylphenidate, donepezil, memantine, or SSRIs, or selective serotonin reuptake inhibitors. These are traditional medications that we use to assist in recovery, but they're not there to create recovery. So, and people always ask me, well, is this going to make my brain, is that going to heal my brain? And I said, no, it's going to help your brain try to connect the dots a little bit, but it's not going to draw the line between them. It's going to be more of using chemicals and neurotransmitters to try to help things start moving along. So these are medications that can assist in recovery. Now, there are some things that are out there that they're talking about for neurostimulation. And people ask me all the time about Ambien. Can I do an Ambien trial? We use these more for our very severely injured patients that we're having trouble emerging them to consciousness. There's a potential that we can trial Ambien for them. Now, Ambien is typically, or zolpidem is the generic, is typically a sleep medication, but it can have some paradoxical reactions that actually can cause increased alertness. Right now, we just have case reports. They haven't done a lot of randomized controlled trials yet, but we have some case reports and some videos of people when they get Ambien or zolpidem. They're awake for a half an hour to 3 hours afterwards. And that's when we really try to do the therapies during that time to try to see if we can help sustain that alertness. So far, what we have seen, once the Ambien or the zolpidem wears off, the level of consciousness wears off. We don't have enough treatment or enough ideas as to why it's only a short-lived improvement and why it's not sustaining. So those are things that are currently in being researched and on clinical trials. There's actually a new clinical trial that's come out in the last year and a half, 2 years, and it's something called apomorphine, where they infuse apomorphine, which helps to increase dopamine in the brain to try to help with neurostimulation. And this is, again, for disorders of consciousness, people in coma, minimally conscious, or unresponsive wakefulness states. Currently, it is truly only in clinical trials, and there are 2 sites, and they have a very strict inclusion criteria process. So, but that is something that's out there, and hopefully we'll be able to get more information. Because we know that the one medication, like I had on the previous slide, amantadine, has a ton of data and studies behind it. It works on dopamine. So trying to see if there's a way that we can get that response a little bit better without having potentially some of the side effects like amantadine does. So, but other things that are out there for new frontiers are brain stimulation techniques. So transcranial direct current stimulation, transcranial magnetic stimulation, and deep brain stimulation. Now with transcranial direct current stimulation, it is a device that's put on the outside of the skull. And it has, so this is where the red is where it actually is giving the electrical stim to the brain. The blue is where we kind of are trying to point the stim towards. So it's trying to get the stim to go through the brain. Normally we put it on the left side or the left dorsolateral prefrontal cortex area, which is kind of on the left temple side of the brain, to try to get that signal to go through. It is a direct current flow. So it has a battery here, but this is actually the device that we use here at OSU. It's called the brain driver device. And you put the one on the scalp, and then you put the other one either on the arm or on the other side of the scalp to try to drive that force through. Now with it, it's really being used a lot for depression, anxiety, and chronic pain. But we have been using it for arousal and alertness as well, and cognition. So you'll actually see, you can get a TDCS device on Amazon, and you'll see people using it for gaming, to improve their gaming, to improve their alertness and cognition. We actually put it on some resident physicians, because they had a test to take to see if they could take the test better. None of them said that they did better on the test because of it, but you know, something to try. So it is something that's out there. The people are using for non-brain injury uses as well. It is really easy to access. It's super cheap. The big thing is potential side effects. So some skin irritation, some tingling sensation. Sometimes people can get tired from it, but otherwise it's relatively well used. Now, the big thing is, though, is if you have any metal in your brain, you cannot use this device. You cannot use it with a shunt. You cannot use it with any type of metal in your head, because the metal will actually diffuse out the signal. And if you have a shunt, which has a metal that's going right into your ventricles, that could heat up and cause internal damage. You do not want to use this with any metal in your brain or on your scalp. So it is something that we have to use cautiously. You definitely want to ask your physician or your if that is something that you can use, but it is something. And also figuring out where to place it, because you place it in a different location for cognition, a different location for depression, a different location for chronic pain. So that is definitely something that you want to talk to your physician about. All right, and then for TDCS, there's other things. So you want to look at if there's any skull defects, if there's any cerebral spinal fluid changes, if there's any shunt hardware, like I talked about. All of those things are definitely things that you need to make sure that are okay to use the TDCS with, because the electrical current can potentially get dispersed or cause other damage, especially onto metal. So you definitely want to make sure that this is cleared with your physician. But you might have to look at, and so what this means is necessitate pre-stimulant current distally modeling. That means is they might have to consider doing like a 3D MRI to see where they need to get the stimulation to, depending on what it's used for. Now that's more in the research phase and everything, so we don't do that for every patient, but we do have patients that we use TDCS for. Majority of what TDCS is being used for currently is depression and anxiety. We use it only on the inpatient units for cognition and neurostimulation. So transcranial magnetic stim. So this is TMS. Its potential uses, again, chronic pain, stroke recovery, depression, mood disorders, Alzheimer's. There's some reports on using it for Parkinson's syndrome, there's Parkinson's disease as well. But the main thing that this one is FDA approved, and people always ask about what the FDA has to deal with devices, but it does. The FDA has only really approved TMS for depression. Everything else, stroke recovery, chronic pain, mood disorders, everything else is still being used experimentally. So again, anything that's experimental will not be covered by insurance. But this is what a TMS chair looks like. This is where the magnet is delivering the stimulation to the brain. So when we look at it, it's a coil inside that magnet, and that creates an electrical field or an electrical current. And then it creates a magnetic field on the outside, and that is trying to disperse that current through the brain. And so when we're looking at things like stroke recovery, they're trying to adjust the location. So if you see, this can be adjusted. There's an arm that can adjust where that magnetic stim is located depending on what they're trying to affect. So but this one can have a lot more side effects than TDCs, so being very careful with that. Again, it's contraindicated with any metal because it's a magnet, and just like an MRI is contraindicated with some metals, especially if they're not MRI compatible, magnetic stim is also contraindicated with non-magnetic compatible metals. So potential side effects can be headache, scalp discomfort, tingling, lightheadedness. It can bring on seizures, mania, so severe mood disturbances, and then hearing loss. We do have to put ear protection on for people. And then deep brain stimulation. So this is the most invasive of the bunch. So this is literally putting a brain stimulator electrode down into the brain. So this is the lead. This is the actual stimulator rod. Comes down through a coil or wire underneath the skin, and it's implanted into the neurostimulator right here in the chest area. So the big thing with the deep brain stimulator, it is the electrode has to be implanted in. There's a pulse that's generated here. So the nice thing with this is that we can get to central structures. If you think about TMS and TDCs, they're all on the outside of the brain, and they have all of this to get through to get to some of those. So that's why deep brain stimulation is being looked at for some of our patients that are in disorders of consciousness or that have movement disorders as a result of their brain injury, because those are affected by these central structures. So with deep brain stimulation, for when we talk about MCS is minimally conscious state and VS is vegetative or unresponsive wakefulness state. There's 7 case reports in the US for that, for a thalamic endpoint, and there's 40 case reports for DBS with VS. And so far, their responses for unresponsive wakefulness is not the greatest, but the responses for minimally conscious has shown, but there's only been 7. So again, this isn't something that anybody's running into with how invasive it is. We need more data and more patients to really determine is this something that we're going to put people through. This is just a little schematic that you guys will have on when the slides are uploaded, or if you already have the slides, to just kind of look at the difference between the different devices and the different targets for them, and whether they're invasive or not invasive, and kind of where how they are affecting things. So if you have any questions about those, I did not talk about peripheral nerve stimulation, vagus nerve stimulation. We use that more for seizure management or seizure disorder management. There were some studies done on trying to see if it could improve motor recovery after stroke, but so far the research on that is inconclusive. So I did not put that on here, but vagus nerve is mostly for seizure disorder management. So people ask me about light therapy all the time. They're like, oh, this doctor came in and shone a blue light in my face, and what is that all about? Well, there actually is some data out there about blue and red light therapy, and doing blue light in the morning to help with circadian rhythms, to promote alertness. And then there is some data out there on red light to improve cerebral blood flow. But all of those studies are still in concussion and mild TBI. There is nothing for severe or moderate. They actually have shown that for severe or moderate, this has not been as effective. It's more effective for our mild TBI or concussion patients. So really what it is you have blue light, you have red light, and then you have the near infrared. And so what it's trying to do is the mitochondria are our big energy drivers in our cells, and it's trying to drive them to kind of create this chemical cascade to help with as an anti-inflammatory, to kind of boost those, boost immune boosters, some growth factors. So it's really trying to get the mitochondria to kind of kick it in gear to help with that. Then it's also trying to help with vasodilation, which means help with blood flow, opening up those blood vessels. So they're showing that red is potentially more effective for the blood vessels. Blue is more effective for kind of all the other things. And then a near infrared, they were saying is the most effective, but this one I'm cautious about just because I don't know the devices that are out there and how they're regulated yet. But there is some data coming out about light therapy. The number one thing is, and Alicia will talk about it too, is, keeping yourself physically healthy, keeping yourself active. Your environment plays a huge role in everything that you do. You can have the best stuff in the world, but if you don't do the sleep hygiene things, you may still not sleep, so medications can only take us so far. Treatments like that can take us so far. It's really, when we look at brain injury, it's schedules, it's creating those environments, it's really giving yourself kind of the best chance to get that recovery. And Alicia can talk about more.
Yeah, I mean, I totally agree. I think that question kind of summarizes the purpose of NeuroNights altogether, right? So we're trying to educate everyone on all the pillars of wellness and how they interact together to create this environment so everyone can have a healthy lifestyle and have a way to promote recovery, whether that's physical fitness or your sleep or finances and your life status altogether. They all work hand in hand to give you the best environment to recover. And in regards to physical fitness and rehab, I mean, I think especially on the outpatient side, we see a lot of people, and we're kind of known as like the last stop shop, in terms of their recovery journey. And we have these conversations with everyone all the time. And we always just say the best thing you can do is subject yourself to the best environment. Like Dr. Bavishi said, the patients that thrive the most are the ones that do the right things, take the recommendations from their physicians and their rehab team to facilitate that recovery. But it's really about what you do day in and day out. Life is beyond just rehab. I by no means want to discredit therapy, because that's what we do, but it's not the end all be all. And individuals really thrive by the work that you put in within your own walls of your home. And so it's really what you do on a daily basis to help manage that, but give yourself grace as well. Your body does need to rest. I like to call it active recovery, where you're maybe not doing like an intense workout, but maybe you're just going for a stroll or a walk with your family and just keeping your body moving. Your body likes to move.
So the main thing that I have to say is that this is a longitudinal process. This isn't something that, I tell everybody, it's a marathon, not a sprint. Rome wasn't built in a day. But at the same time, the data is out there that, the survival rate is increasing for brain injury patients. The patients that are surviving with ongoing disabilities are still there. But as long as we continue to keep ourselves healthy, we don't know how a brain regenerates. We don't know, that we talked about stem cells last week. We don't have the answers to say, hey, things will, in 15 years, things may be different. So if you can keep yourself healthy, keep continuing the progress, keeping things as maintained as possible, that as these new theories, new innovations come out, there might be something out there. We just don't have the longitudinal data yet, which you would think, we've been dealing with brain injury and doing some of this stuff since the 70s. But really, we're getting a lot more, with CTE and with the conflict, there's been a lot more focus on TBI. And we're very grateful for that, because there's so many survivors in the country and the world with TBI. And there's so little that we know about the brain, even with all of this. And so the main thing is, I'm very proud of your daughter for 14 years, having continued on, but just continue that, maintain that, because we don't know which one of these treatments could potentially be out there for our chronic survivors.
Yeah. And the only extra thing that I would say, if you're asking specifically about like rehabilitation strategies, this is kind of where I think on my soapbox a little earlier, I was saying about you can use your rehab team as almost like a primary care specialist, right? You go to them for your annual physical exam. Sometimes when there's neurologic compromise, you need a little bit more than that. So sometimes we get patients that come in for that quote unquote tune-up because 14 years ago, I was on a PT, but the technology between now and then has drastically evolved. So I'm not sure of your daughter's current functional status, but bracing is always evolving. The technologies that we can use to help people try to walk again, in terms of body weight support, treadmill training, or body weight support, walking over ground, electrical stim, to try to get those muscles firing. Like Dr. Bavishi said, it's a longitudinal path. And although we might not see as much change now, there is still the potential for change. And so it doesn't hurt to ask the right questions and to explore those options for you and your daughter. The big thing in terms of rehab, in terms of getting picked up, is usually we need a functional goal. And insurance wise, a lot of times we have to just show progress. So we can evaluate you or your daughter. We can try new things, maybe strategies that haven't been done to her with her rehab journey, and work together with your team to try to see if there is ways for you guys to navigate and or improve walking and cognitive strategy. So I hope that's helpful for that question.
So diffuse axonal injury, we're using an MRI to evaluate diffuse axonal injury. So what we do with that is we look at the severity of the diffuse axonal injury. So the MRI will help us determine, there's 3 grades of diffuse axonal injury. Grade 1 is between the gray and the white junction. So where the gray matter and the white matter of the brain come together is where grade 1 diffuse axonal injury was. That's where there will be shearing between those 2 areas. Grade 2 is where you have the gray-white junction. You'll have some small hemorrhages there, but you can also have some in the corpus callosum. The corpus callosum is the part of the brain that connects both halves of the brain, the right and the left brain. And then when we look at grade 3, that's where we're looking at diffuse axonal injury that could go into the central structures like the brain stem. And so if we have diffuse axonal injury going into the thalamus, into the brainstem, into the areas that are for arousal, that would be where some of our patients are staying in a disorders of consciousness. So the MRI really helps us to see how severe or what grading the diffuse axonal injury is, and that helps me to predict recovery and also to predict outcomes, and also what kinds of things I may need to do for patients. Because like the brainstem does a lot of our automatic functions. It does our breathing, some of our automatic heart rate, blood pressure things. So it helps me determine, am I going to have someone, that's going to have trouble with breathing, with needing tracheostomy, that type of thing. So the MRI with diffuse axonal injury will tell me how to grade the diffuse axonal injury. No. So that's a very good question. So we have so much technology in this world, but our MRIs still cannot, and our CAT scans still cannot tell us if something is chronic beyond 2 weeks. So like our CTs and MRIs will say, okay, this was subacute or this was acute But then once it gets into the 2-week or longer phase, it all looks the same on MRI. So they can't tell you if this is something that happened 2 weeks ago or 3 weeks ago or something that happened from 10 years ago. It's going to look very similar on the MRI. So we don't have enough data or enough power with the MRI to see those small little things that are happening on a microscopic level yet. Hopefully with the DTI, we might be able to see that, and that will give us more data. We currently, with our current MRI capability, we don't have that capability.
And can I just kind of follow up to kind of clarify something in here? So when you talk about, we're doing all this work with DTI, for example, and you want to get more data, it's not about having people go through the scanner. It's about having people go through the scanner and stay with that research study for 5 years or 10 years, and the same person in the same scanner, right? And so that becomes very difficult to do. It's just it's hard to do it.
Right. Because for example, like if I had a brain injury and you had one, Kadar, we could both go through and our brain imaging looks very different. But if I don't follow up in 5 years and you do in 5 years, they can't correlate what happened to you in 5 years to what mine could have looked like in 5 years. Because as you guys all know, no two brain injuries are the same. And same thing with the imaging. So we won't know, I can't say my imaging is going to look exactly or have that much change as Kadar's would in 5 years. So 100%, getting involved in research studies and sticking with them through the duration of the time that they are predicting you'll need to be is going to be very helpful for us, for sure. Medical marijuana, when you look at the approved list of approved diagnoses for medical marijuana, TBI is one of them. And medical marijuana, I find, helps with a number of different things, but can also have a number of different side effects too. So let's start with what it can help with. Help with mood, helps with anxiety, can help with spasticity, can help with that kind of those mind racing thoughts to help people go to sleep. So it can be very beneficial. But on the other hand, depending on what is in the medical marijuana, what kind of THC is in there, what kind of CBD is in there, it can cause cognitive slowing. So when you look at the data out there for TBI and medical marijuana, it's really a lot of case reports. There's not a ton of randomized controlled trials. And the few that we have out there do show that there is some level of cognitive slowing in brain injury patients, but it may, if it helps with other things that preclude function, then we have to kind of say, outweigh the benefits and the risks at that point. But there is data out there that shows that it can cause some cognitive slowing, not for everyone, not across the board, but there is some data on that. But for the most part, depending on what's in the medical marijuana is where the question lies. And that's why, when it first got passed in Ohio and there was such regulation on, where it was being processed, where it was going to be distributed, and everybody's like, why is this taking so long? I'm actually really glad they did that, because then we can really make sure that what's coming into the dispensaries is as controlled as we can get it. And so that will help with making sure that we're getting a use of it that is controlled and that people can have, that's going to be steady and even, rather than, when you're asking about CBD oil. I have people ask me about CBD oil every day, and they're like, where should I get it from? I'm like, well, I really have no idea. There's no FDA regulation on it. So I don't know which one is going to has the true percentage of CBD that they're talking about. And there's so many different companies out there now making it, and they're not regulated. They just have to put a label on there that says they're, potentially the USHA certified, but USHA certification is not a FDA certification, or it's one that they can pay for to have that label slapped on there. So that's the main thing is, we don't know what kinds of THC and what kinds of CBD are in some of these products. But we do know that it has some efficacy. We just have to outweigh the risks versus the benefits. Yes, it could. And nightmares are definitely something that I see quite a bit of after brain injury. Usually it's on the milder brain injury because they have more of recollection of their injury and less time for post-traumatic amnesia. So I usually see them with our mild brain injury or concussion patients. I also see them a lot with our returning vets. But yes, nightmares or night terrors can possibly lead to confabulations because people will live in those dreams very vividly, and then the next day they'll feel like it actually happened to them. And so they will talk about this whole story, and then we'll recognize it can go through dreams.
The vision as well is really tricky because it's not just always following up with your traditional optometrist like you go to for your annual exam. And a lot of people don't know that. There are things like neurooptometry and ophthalmology, and there's a whole bunch of specialty areas when it comes to vision. At Dodd, they have a neurovision clinic, and then that also translates over to outpatient. And they can do different assessments. It is much more helpful. And when I work with our occupational therapists and optometrists, when someone can verbally respond so that we know what they're seeing, but Dr. Bavishi can take over, there's definitely ways that you can do that without verbal or cognitive reply.
Yeah. And some of that is doing things like, like in pediatrics, we talk about how we review kids' vision, and they can't always, follow a specific format or like, the letters on the wall, or they can't read them. So we look at different things like their tracking. We'll have them track different things. We'll see if their eyes stop moving following something. So we'll look at visual fields that way. If they are able to do a little writing, even though they can't verbally respond if they have aphasia or something. But we'll put some papers in front of them, see if they can point to different words if we're asking them to, so that they don't have to verbally respond. There'll be different things where we're having them try to color, like, a lot of familiar tasks, or putting together a puzzle, and they may only put together the left side of the puzzle instead of the right side. So there's a lot of those kind of tasks that we can do for looking at vision without verbal or cognitive, like without verbal responses. And cognitive wise, we do more of looking at, the optic nerve and looking at the retinas and all of that by doing dilated pupil exams and that type of thing. So flashing lights, kind of moving things around in front of people to see if they have any responses with their vision. So if they can't cognitively respond. So there are some of those interventions. Good question. And yes, you should not do it if you have metal in your mouth as well, because of the way that the current can go through. So yeah, and that was exactly what I was going to say. Coming up, we have the Integrative Medicine Center that's going to be doing some of those holistic therapies and doing some of that education coming up here in June, which we're super excited about. But from just an overall, in general, fish oil does have some data behind it. And they talk about the type of fish oil and how to store the fish oil and that type of thing. It doesn't have, it's getting some on the more of the cognition and also on the alertness standpoint. B vitamins are always good. The nice thing with them is they are water soluble. So if there's too much in your system, you just urinate it out, and you might have really bright yellow urine. But B vitamins are very much known for nerves. So B12, B1, B6, they do help with nerves. So those are not a bad thing to use. And then when we talk about things like turmeric, I grew up with traditional Indian Ayurvedic medicine. Turmeric was pretty much in everything that I grew, and my grandmother and my mom put it in everything, in our milk even. So turmeric is a natural antibiotic. It's a natural anti-inflammatory, and it's something that people in Eastern medicine, especially in Ayurvedic medicine, have been using for years. And it's really, don't just eat it, though, the yellow spice, it's very bitter. But the turmeric pills are fine. Putting a little turmeric in, your cooking or whatever is okay. So it is a natural anti-inflammatory, natural antibiotic. And then when you talk about the reverse osmosis or purified water, so the metals removed. So this is the tough part because, we have such processed water here in the US that we technically we should not have heavy metals in our water, but we definitely know with what happened up in Michigan that wasn't the case. And so there is, of course, there are things like lead poisoning and heavy metal poisoning that can happen. We don't, in Ohio at least, have water situations like that we are worried about heavy metals. And right now, there are some metals that we need to have. There are some things that people can have copper deficiency and iron deficiencies and those things that can cause other problems. So right now, I would not look at the purified or the reverse osmosis water as being a huge thing, just because we live in a first world country with a very good water system, technically, unless there was an issue in your state. But we don't live in a third world country where it's difficult. Now, when my parents live in India, I do tell them to do their reverse osmosis water and not drink the water out of the tap, because we don't know what their filtration system is like over there. But here in the US, we're very fortunate. So from that standpoint, I don't usually recommend anything like that. And then aluminum products. So those are things like a lot of the deodorants have aluminum and stuff. And there are some concerns about that from the cancer standpoint, but we currently don't have a lot of concerns about that on the brain injury standpoint, but it is something that overall health-wise is something we should minimize anyway. So it can help with your overall health. It's not just necessarily just brain injury.
NeuroNights is financially supported in part by the undergraduate student group Buckeyes Raising Awareness in Neuroscience, mainly through funds raised at our annual Brain Injury Awareness 5K run and 1 mile walk. You can learn more about the event or donate at go.osu.edu/BIA5K.